Hi, this is Junaid with another lecture on acute ischemic stroke. Today we're going to discuss the second of the lectures of secondary stroke prevention. The main topic we're going to discuss is untitled robotics. And in this situation, the first and the foremost is the non-cardioembolic. In the non-cardioembolic, that is basically subcortical infarct, small vessel disease infarcts, there's no reason of using oral anticoagulants. Antiplatelets are the way to go. The level of evidence is significant, and the class of recommendation is one. Selection of the antiplatelet agent is technically according to the individualized patient. If the patient already is on aspirin and Plavix, you get the P2Y12 level. The aspirin is working or not. You get the aspirin response level. If the aspirin is actually responding or not, you may have to go to Berlinta. Depending on your patient's individualized patient profile, you have to choose the antiplatelet therapy for that patient. And the class of recommendation is one, so there is no real guidance from really the guideline perspective on which antiplatelet to choose. Aspirin increases, so if you look at the last one, for patients who have non-cardioembolic ischemic stroke, while taking aspirin, increases the dose of aspirin or switching to an alternative agent for additional benefit in stroke prevention is not well established. And this is really where the cutting point is, basically. If, for example, the patient already is on 81 milligrams of aspirin, comes in with another TIA, you can switch to 325. Sure, I mean, treat yourself, but to be honest with you, there's no real data to actually say that this actually makes a difference. Even if you're switching to Plavix, may actually not make a huge difference. The real question for me always is that are they aspirin non-responders? So if you get the aspirin response and clearly they're not responding to aspirin, then switching around may actually be beneficial in my opinion. Again, there's no data actually driving that decision. Similarly, if you're looking at the patients, do you really need to have a coagulation testing done for initial stroke? Not really. Switching to warfarin is not indicated for secondary stroke prevention in non-cardioembolic strokes. Let me give you an example. So if the patient is already on aspirin and Plavix, P2Y12 level is good, aspirin response time is good, but it still comes in with a stroke. What do you do next? Do not switch to anticoagulation. Switching to warfarin is not a good idea. It actually increases the risk, and to be honest with you, the mechanism of small vessel non-cardioembolic stroke mechanisms are plaque-related. So therefore, an antithrombotic choice will be antiplatelets rather than anticoagulation. So make sure that you are actually choosing appropriate to the patient's disease mechanism in these situations. If you are using triple therapy, including aspirin, clopidogrel, and dipyridamole, this is actually a recipe for disaster. Clearly, if you have to go above and beyond like that, to be honest with you, what happened, to be honest? Patient actually had more than one stroke. And then you actually are escalating therapy, but at a certain point, you just shouldn't escalate medical therapy, and you should just make sure that the patient understands the risk, because at that point in time, you are not increasing the benefit, just the risk. Atrial fibrillation, the important thing is that it is reasonable to initiate anticoagulation. The always question is when. And for me, it depends on the stroke volume. If the stroke volume is small, I start it the next day. If the stroke volume is big, and the patient are actually, depending on where they are, the latest I've started is actually around 14 days. Generally about 3 to 7 days after repeating CAT scan, making sure there is no hemorrhagic conversion, I start them on an anticoagulation. The choice of anticoagulation, it depends again from person to person. Generally, they have been using newer DOACs, the Eliquis, etc. Do you add antiplatelet to anticoagulation in atrial fibrillation patients? So generally speaking, if you're using a small 81 milligram of aspirin with concomitant carotid disease or cardiac disease, I think it's reasonable. But if you're adding more than two antithrombotic agents, one being anticoagulation, one being antiplatelet, you have to be very careful, because at that point in time, you're basically increasing the risk. I had to do it in some of these patients. The patient actually required acute carotid stent, found to have atrial fibrillation. I need to give Plavix for the stent and aspirin. So again, for 90 days for a small stroke course, sure. But at the end of the day, you need to make sure that you communicate the risk of bleeding to the brain, to the patient, and then also have a timeline when to stop those things. So at the end of the day, the real advantage is not there. And again, these patients would definitely benefit from lifestyle modifications as well. And those things need to come up in front. So these patients can, benefit from lifestyle modification talk as well. Arterial dissection. So There's always been a talk that what is the recommendation? Is it antiplatelet? Is it dual antiplatelet? Is it anticoagulation? Here's a simple truth about it. No matter if it's carotid or vertebral, at the end of the day, you can use either for 3 to 6 months. I personally use always antiplatelet. Why give the additional risk of bleeding if either is working? So, in my opinion, use antiplatelets for 3 to 6 months, both external carotid and then vertebral. Hemorrhagic transformation. In those patients who have hemorrhagic transformation, discontinuation or continuation is a very individual decision. If it is just a particular hemorrhage, to be honest with you, sometimes I don't even stop antiplatelet if it's just aspirin. But if it is something that the patient is actually have a true hemorrhagic conversion, then definitely I stop it, even sometimes to stop DVT prophylaxis. So continuation and discontinuation should be weighed against the risk and benefit, what is patient's blood pressure control, etc. Okay. Carotid vascularization. This is another thing that has changed seriously. This is a new recommendation from the last guidelines. If you have the capacity to get the revascularization done in a subacute phase, that is between 48 hours to 7 days, it is reasonable to do so. If the patient actually has a large stroke, if you're considering that the revascularization can cause hemorrhagic transformation, then you should wait. Again, this is a little bit individualized way, but if you look at the class of recommendation is now 2 and the level of evidence is B. So there's more and more data that is coming out that initial acute, subacute revascularization may be considered in these patients. Thank you so much for your time.
Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.